Hi, everybody. My name is Prachi Bakarania. I am one of the scoliosis PTs here at Columbia. I'm so happy you guys are joining us for this webinar. Today, we will be speaking about assessing and treating the adult patient with scoliosis, sometimes with back pain, sometimes not with back pain. We can't wait to get started. Before I get started, I just want to let everyone know that our next webinar, our final one for 2025, will be on in October. And it's about providing holistic patient care through mental health, addressing compliance and anxiety. Dr. Choi and Julia Rakin will be joining us, so I hope you guys can come.
Yeah, super exciting, Prachi. We've done a lot of work, as you know, in the area of holistic care and mental health. And I look forward to sort of hearing a little bit about the update there. I also just want to take a second to thank our guest speakers today, Alessandra Negrini and Amy Sbihli. I really appreciate you spending some time with us and teaching us a little bit about your perspectives about the management of adult scoliosis. And
Thanks for all your support, Dr. Vitale. We couldn't do it without you. So thank you for giving us this space. So let's jump in. I'm going to introduce our two speakers, Amy Sbihli from Boston, Alessandra Negrini, all the way from Italy. Between the two of them, we have decades of experience treating patients with scoliosis. Today's talk will be primarily on the adult with scoliosis, either the one that had adolescent idiopathic scoliosis and now is an adult, or a de novo degenerative scoliosis. And initially, we were going to do a more didactic talk on, measuring clinical radiological measurements, and found, as we were discussing, that a lot of the webinars already covers this. So instead, we really wanted to think about how to really use your clinical reasoning tools, how to hone in your assessment, how to really think carefully on what you are advising your patients to do, and really helping them set realistic goals. So when a patient comes in, with scoliosis, especially if they have pain, generally you want to know, is the scoliosis the source of their pain? And in this population, just as a general scope, the patients with the thoracolumbar lumbar curves, if their pain is at the apex, if they have cruralgia, meaning pain in this anterior thigh, if it's more from a rotatory component, then we're really looking more on seeing if we can directly impact their pain, not all the time, but sometimes. And this list in front of you is not an expansive list. It's just a list that the three of us put together, and we found that we kind of measure all the same clinical tools. And this is extremely important because these tools will help guide your interview, your decision-making process, and really helping your patient make realistic goals. So really making sure that you are very consistent in how you measure will go a long way. So without further ado, I want to pass on the baton to Amy, who will talk a lot about how she has changed her practice and how she screens patients and really thinks carefully on setting realistic goals. Thank you again, Amy, for joining.
Thank you. We decided to put the goals of treatment right up front, kind of as the beginning bookend of this conversation, just to initiate the thought process of, like Prachi said, all the things that you're going to look at when you meet somebody. So the primary thing were the kind of the first couple bullets, especially reducing disability and improving function, getting the global balance primarily in the sagittal plane as a focus, especially in the beginning, reducing the energy needed to maintain the posture. And you can see improving quality of life, decreasing pain. And education is a huge part of the time that we spend together beyond just exercise education on joint protection, pacing, ergonomics, the things you learn as a general physical therapist without PSSE special training, and promoting a healthy lifestyle. So let's go ahead and look at how my practice has been evolved a little bit. So you can go to the next slide. Typically, I will meet an adult who is curious about non-surgical care through a phone call or an email. And I invite them to my office. I call this first moment that we meet together a free screening. And In the beginning, when we first meet, I kind of ask them to share their journey. So yeah, we'll stay right there. And I'll ask them during this time if they have a medical doctor that knows that they have scoliosis. Is it their PCP or a specialist? And does that specialist know that they're coming to seek care from a physical therapist? I ask them what other non-surgical treatments or exercises they've tried. And through this conversation, if I've not already learned from their story, I will ask why they're seeking care, how they're currently functioning, and what they hope to achieve. Then I'll follow with a brief screening of maybe the Adams 4 bend test, general mobility. I'll watch them walk a little bit. And then if they brought MRIs and X-rays, which I ask them to, I'll just do a brief scan of those while we're together, not the deep dive quite yet. Then typically they don't really know what PSSE is, so I will take some time to explain what it is and what the goals are to support function, reduce symptoms, and really learning about their specific curve type and their compensations, especially their compensations during normal activities, is something that they will learn. If it seems like this is a match for what they're looking for, I will recommend a plan of care with the frequency and duration. And if it doesn't seem like a fit, we might talk about a referral out to another healthcare provider or back to their PCP, whatever is appropriate. And then last, I'll always recommend that they consider when they start their program. This age group typically is very busy, and they can have other medical comorbidities that they might be managing. I mean, anything from work on their teeth to hip replacements. They can be very busy with family obligations. Maybe they're caring for a loved one. Maybe they are an accountant and they have really strong work deadlines. Sometimes I'll say, don't start during tax season. So I do want them to know that I want them to be able to dedicate 10 to 30 minutes a day for home practice. So while we're meeting, they can ask questions when they come back that we can address. So if I could really dream up the ideal patient, and I was thinking about this while we were preparing, I would love to see that ideal patient be somewhere between 18 and 65 years old. Their SRS 22 scores would be 4 or higher. Their ODI would be 30% or less. And they would be active. They would be seeking care to support them to stay active. They'd be asking for ideas for reducing symptoms with their activities of daily living, such as like sitting in their car, sitting at their work desk, lifting heavy objects so that they can keep cooking, gardening, or traveling. And a lot of them ask about their exercise routine, asking for modifications so that they can educate their personal trainers, yoga instructors, and Pilates helpers. So the next slide, please. I would caution if a person is able to function 100% and has no pain, and their primary complaint is that they're not happy with how they look. It's not that you turn them away. It's just that you need to be very clear about the expectations that we have with PSSE, which is primarily to improve function, pain, and quality of life. And we also have learned that there's not evidence showing that there's significant change in self-image using PSSE. So next slide. So in most cases, this process that I have before actually getting to the evaluation really helps. But I had a case this year that I thought I'd share with you that was different. So the person came in and she said she was 38 years old. She's known about her scoliosis since she was a teenager. She reported that she was newly a single mom due to divorce. She moved to a new state without a job or family, and she was raising a 5-year-old daughter. She had seen a PSSE therapist 10 years ago, and she was currently not having any pain and said she was staying busy just being a mom. So she was asking for a refresher. She said that when I did PSSE in the past, it helped me get back on track and feel good. So I'd like to get back on track and feel good again. So we created kind of a short plan of care of 5 visits, 1 hour each for 5 weeks, just to kind of see if that's all she needed to get back on track. So typically, after this conversation happened, I would send intake forms to their patient portal. You can go ahead and go to the next slide. So I just put some of the questions that are on this intake form. Some of them just reinforce what we talked about during the screen. I do turn at this point would ask for the SRS 22 and ODI to be complete. And in most cases, this pre-eval process reinforces what we talk about. I can ask clarification on anything that kind of pops up through asking deeper questions. Things like sleep disturbances, incontinence, reports of anxiety and depression, bone density. I also ask the preference of learning style. So we'll go into some deeper conversations right before the evaluation. And in general, like I said, this helps me prepare for the evaluation that I'm going to do before I meet them in the office. In this particular case, this year that surprised me, we didn't send forms to her because she wasn't ready to start her plan of 5 visits. And 5 weeks after our screening, she called rather urgently asking to get in as soon as possible. I happened to have a cancellation, so we could slide her in that week. We sent her the pre-assessment forms. Unfortunately, she didn't get to fill them out until right before her visit. So during her visit, I was reading through them at the time of her arrival. I noticed that her SRS 22 scores were 3 for pain, function, and mental health, and 2.8 for self-image. Her ODI was 40%. Her subjective report had a significant change. She reported that she had started work. And after our screening, she went to a physiatrist who did an x-ray, who said the x-ray had no change from her prior x-ray. She informed me that she was assigned a new PCP. She had not met with this PCP because the office space was pretty far from her home. I also noticed when she was standing, she was holding herself up with her hand pressing against her thigh. She said she didn't have any pain at work, but she was only able to walk about 10 to 15 steps before she had to sit down due to fatigue. So even before I went through the evaluation, and Alessandra is going to help us with a more thorough evaluation, I started just throwing out a couple ideas to her, like walking sticks to help her with some endurance. She said she couldn't use those because her daughter would laugh at her. I offered different ways that she could play with her daughter that might be less painful. She said her daughter wouldn't like that. When I talked about other activities that she told me she liked when we met for the screen, like her favorite activity was swimming, I said maybe she could go back and do some of that to help her build some endurance. And she said she couldn't figure out when she would do that. So, based on multiple things that you can hear through this experience, I didn't feel like she was a candidate for PSSE at this time. So I recommended that she reached out to her primary care doctor for a more thorough investigation of her recent physical decline and to consider asking the doctor if maybe general deconditioning physical therapy would be better for her than PSSE at this time. So this was an unusual event for me. Typically, that screening process and then getting those evaluation forms before that I can read before the person even shows up and I have their x-rays before they show up for their visit typically sets me up well with this person, knowing what they're coming in for, what they are confident that they've chosen the right time and what they're going to do and what they are going to hopefully achieve from the visits that we have together. So, Alessandra, you're going to go now into the detail about how you assess.
Yes. I want to present you the main clinical tests that we can propose to adults. They are quite similar, even if there are some differences to the tests we propose to children and adolescents. The Adams test, the evaluation of the coronal balance, and of the sagittal balance. All these measures are important to guide the choice of these movements we must propose to the patient for the self-correction, and also to check what is changing in time during the follow-up due to the pathology or due to the treatment that maybe changes these results. Next slide, thank you. The most known, the most used test is Adams test. And in children, we propose it every 30, 45 days because we physiotherapists see more often patients than doctors, just to check if something is changing. You know that intra-rater measurement error is of 2 degrees. So if we find a change of 3 or more degrees, we can refer to the doctor. What about adults? Adams test has never been tested on adults. It has not been validated on adults. We don't know if the ATR in adults correlates to COP degrees. We don't know if a change in ATR degrees correlates to a change in COP degrees. And you know, in adult scoliosis, for example, in the novel scoliosis, there is a lot of rotation. And maybe even though the novel scoliosis has usually just a few COP degrees, there is a lot of rotation. So this may influence the validity of this test. However, we can measure and just knowing that we cannot trust so much this measure. And another test that comes with the Adams test, when you ask the patient to bend forward, you can ask the patient to bend on the side while he's bending forward. And St. Coilu validated this test that is very rapid, very useful to check the stiffness of the curve. The stiffness of the curve in a child tells us which curve probably will progress more because it is the main curve. And in adults, it can help us to understand how much correction we can ask to that patient of that curve just because of the stiffness or of the mobility of the curve. Next slide. Coronal balance in children and adolescents is not a risk factor. The fact of having a coronal imbalance till now has not been shown that it has an effect on the progression of the scoliosis. In adults, it is a risk factor when it is on the side of the concavity. We check coronal balance because we want to give a better balance to the trunk of the patient, also to improve the function, to improve the quality of life, because a trunk that is imbalanced probably will give problems in standing for a long time, in walking. And however, in adults, the fact that there is a coronal imbalance is not correlated to the pain of the patient, to the function, and to the quality of life. So we can consider it, but we know it is not the main measure, the main aim of our therapy. Next slide. In this patient, you see there is a lumbar curve, a main lumbar curve, and the imbalance is on the side of the convexity of the curve. So this is not a risk factor for progression in adults. As I was telling you before, the risk is higher when the imbalance is on the side of the concavity of the curve. So the progression will be faster. Next slide, please. The other measure is the clinical sagittal balance. In the clinic, it is a test that is like the sagittal vertical axis in the X-ray. This measure that we are validating with the study just in these days helps us mostly with adults, because in children and adolescents, usually there is a good overall sagittal balance. During growth, it doesn't change, it is stable, and it has been measured just in kids 6 to 18 years old. And in healthy kids, it is from 5 to 35 millimeters. In adults, a sagittal balance going forward, that is forward imbalance of the trunk, is correlated with pain, with loss of function, with reduction of quality of life. So this is a main measure for adults. Since we usually don't repeat X-rays every 3, 6 months, 9 months in adults, but usually after every 1, 2, 3, even 4 years, we should measure clinically what is changing and how we start and what changes with the treatment. Next slide, please. This is, I just show with some photos and a video how you can measure, because it is a very, very fast measure. You can use a laser line or also plumb line, and you can put your laser line at any distance from the body of the patient, because you just have to subtract the measure of C7 of S2 to the measure of C7. So you measure the distance to C7, then to S2. Go to the video, please. Okay, so you measure in this 84 years old woman, you see it's 165 at C7. We have 50 at S2. The distance is measured in between, in the middle point between the two PSIS. And so the measure that should not be more than 35 millimeters, in this case, is 115. It is important for about all these clinical measures we can propose to our patients, that we measure our patient. We should not, I don't say trust, we trust the measure that the doctor probably did before referring the patient to us. But since we must repeat them and the inter-rater differences are much higher than intra-rater differences and the measurement error is higher inter-rater, we always should measure our patient and then check in time what is happening. The frequency of this test I propose is to repeat it at the beginning of the therapy every 1 to 2 months, and later on at least every 3 months. Go on, please. What happens when sagittal imbalance arrives in adults? Usually, what in adults, even in healthy adults, all the lifelong, the lordosis reduces. It increases up until the end of the growth, and then slowly it starts reducing all the lifelong, while kyphosis is increasing all the lifelong. So there comes a discrepancy between these two curves, and with the reduction of the lordosis, with the increase of the kyphosis, the first way to compensate is a back tilt of the pelvis. This is the easiest and the less energy consuming compensation that we can make. And as soon as the pelvis is going into a complete back tilt and we achieve a total extension of the hips, at that point, to try to maintain the horizontal gaze, the knees start to bend. At a certain point, when the knees are too much bent and it becomes tiring for the patient, then the patient starts falling forward. What I want to stress is that, next slide, please. We should consider this risk when the patients are still young. This woman, she has a 68 cup degrees lumbar curve, and she's 38 years old. She is quite young. But if you look at her spine, both clinically and in the X-ray, you see that the sacral slope is reduced, lumbar lordosis is reduced. There is a tendency towards thoracolumbar kyphosis, and you see the back tilt of the pelvis. Knees are still straight, but everything is getting prepared for this evolution into a progression into a forward imbalance. When the patient is still young, you can do a lot to prevent it, all the life long. While later on, next slide, please, it becomes almost impossible. What we can do for an old patient that has already fallen forward is just to help a bit, but not change things. So let's check what is happening in our younger patients. Prachi, I give you.
Thank you so much, Amy and Alessandra, for offering so many insights. During our many discussions, I learned so much from both of you. And Alessandra, you said something really interesting, and I'm going to ask for you to speak on it. You had mentioned there are many physiotherapists in Italy that when they get, for example, this patient in front of us, especially when they are having pain, they will train them only in gravity-reduced positions, supine, side lying, and never introduce gravity. And I asked you to just speak on that a little bit because I thought that was really interesting where in theory that makes sense, but our life is lived not laying down, right? We live in standing and sitting and bending and reaching and moving. So tell me your thoughts.
Yes, when a new patient is coming to me and I assess and I ask some questions like Amy, very similar to the ones that Amy presented, I always ask what he did before coming to me. So if any exercise was done before. And many times the answer is yes, I did maybe for 6 months, 1 year, 2 years, 3 years, some specific exercises or so-called specific exercises. And usually, very often, what the patient was doing was just lying down exercises, nothing sitting, nothing standing. Probably because the physiotherapists who proposed these exercises did not feel so much confident in what he could propose to a patient, not just a patient that has already fallen forward, but also a patient with severe scoliosis. They see they cannot reduce something that is already stiff. They cannot try with any movement to reduce the curves, so they just let the patient lay down. This does not harm the patient, but probably does not help the patient, because laying down, for sure, what we saw has been seen in this study that is quite old, but is still actual, is that there is a difference between standing and lying position. It's 9 Cobb degrees, in whatever is the size of the curve. And just letting the patient lie down and doing breathing exercises, stretching exercises, maybe also core stability exercises, we cannot get what is the most important help we can give to this patient. That is learning, being able to contrast the gravity force. Because at the beginning, the forward imbalance starts because of these compensations. But then when it reaches a certain point, it's just gravity force that pushes the patient even more forward. So to be able to contrast the gravity force, we need exercises in gravity, in standing, in sitting, that is everyday life exercises. what I see in this patient is that sometimes you get the ability to maintain, to reach and maintain a good posture, but as soon as the patient starts walking, he falls forward. As soon as he gets something from their back, they come up and they walk in that forward imbalance position. So we need to get into their lives and lying down exercises may prepare, may be useful at the beginning if there is pain, but as soon as possible, let's move into sitting and standing exercises.
Thank you so much, Alessandra. And I think that sort of leads to the next discussion that Amy very thoughtfully brought up. And we all sort of agreed that making our patients as strong as we possibly can, but very thoughtfully is very important. And I think Amy had very good insights on how to be cognizant about mechanical loading, and really being thoughtful on how to set up exercises, mostly weight training with resistance, to make sure your patient is realistic and effective. So thank you so much, Amy.
Sure. Yeah. One of the other things that when we were meeting, we noted was that in Italy, there was fear of overloading and the patients were lying down. And I feel maybe exactly the opposite in United States. Even if it's not a physical therapist, any healthcare, or let's say non-healthcare provider of exercise tends to go first with loading. And so this can be a problem in some of these cases. So with or without scoliosis, we see postural decomposition and a combination of bony degeneration and muscle imbalance following. And loading in this posture can lead to more decompensation in the direction that's already present. So in this case, I call him a good candidate. He very active, feeling not a lot of pain. He has pain, but it's kind of on and off, not constant. And he was sharing with me the things that cause him pain, and he had goals of reducing risk of progression and reducing his pain. So next slide. He told me that the ways that he's been working on staying strong, he was going to the gym 3 times a week and the lifting weights for a majority of the time that he was there. Also walking on the treadmill for 30 minutes if he was there. And then on the other days, he was just walking for exercise at home. His personal trainer gave him a kettlebell to walk on one side of his body. So just looking at the frontal plane here, you can imagine that his left thoracolumbar apex would create some side bending here. And when he would carry it on the right side, he showed me the left side and his pelvis pushed off more to the right. So just falling right into the compensations that he uses to get through life. He gave me other examples like shortening his rectus. You can see in the sagittal plane that he is already in that posterior pelvic tilt. He is able to keep his knees straight, but I feel like he's a heartbeat away from them not being able to stay straight, as Alessandra was speaking about. They also gave him scapular muscle strengthening, so flattening that thoracic spine even more than it already is, because that's a compensation for the kyphosis that he's now kind of acquiring at the thoracolumbar junction. So he has a flattened lumbar lordosis and a thoracic reduction of kyphosis. So doing things to make that more, let's say, tight and strong aren't necessarily positive compensations. And then strengthening his pecs with his head already being forward. So some of these things, are very common that I hear, and we just need to talk about, I want you to continue to do everything that you want to do. Let's just do it better. Let's do it smarter. So you can go to the next slide. So the interventions that we focus on, and I mean we, meaning Alessandra was, and I think Prachi too, we all kind of associated with these things, that we want to teach them about their spine and we want to show them how to autocorrect and kind of unload those mechanical stress areas. And I typically start in non-weight bearing to teach them about how they're using their body, so that we can kind of break down some of those patterns. I definitely think about this as a neuroplasticity situation. It's not all mechanical. I'm trying to down train them in the areas that they've been overusing for their stability and balance in the sagittal plane specifically, and then try to build up a new plan. And that's where I hope with repetition, we're creating that neuroplasticity. I'm definitely doing manual release during exercises to help support the change in their body and the soft tissue aspects to reduce that load. And then we go through all the things that they're doing. I mean, from sleeping to driving, all of these things. I think all of us as physical therapists, I don't need to read the list. We all are trying to do these things with even non-scoliotic patients. So that's just to kind of emphasize that education is a really important part. It's not just all about the exercises themselves.
Thank you so much, Amy. This was wonderful. Before I sort of wrap up the presentation part of things, I encourage everyone to really think through some questions. We have two experts in the field who are ready to answer questions. I hopefully, so far in this talk, the largest things I want you guys to take away is really setting clear expectations, making sure that your patient understands their condition. And that comes from a very detailed interview, eval, clinical measurements. And this way you can set up strategies for your patients to help them improve their posture, improve their mechanics, and then be able to build strength in a very long-term functional way. And also, hopefully, throughout this process, you're teaching them ways that they can provide comfort, teach them how to relieve some of their pressure, and hopefully, if we're lucky, decrease their pain. But in large part, we are making sure we are telling our patients that you will still have a scoliosis. This is structural. So as we're waiting for some questions to come through, let me jump in and ask about this new area that I am thinking more about, especially as I'm seeing more of these patients. Is what are your thoughts, Amy and Alessandra, on the patient who has poor bone density, but they are very nervous? So they've seen the doctor. The doctor has advised them you need to be on an intervention. You are very frail, but they don't want to. They're nervous of movement, and it's very clear their world is becoming smaller and smaller. They're not leaving the house as much. They're not standing up as much. They're not walking as much. And they're here for you to say, fix me. Can you fix what I'm doing? But I don't want to do anything my doctor is saying. So, Alessandra, I'll have you start. What are your thoughts?
Yes, when the patient refuses the drugs that were proposed and the patient with osteoporosis, I think that our role is to guide the patient towards a better informed decision. Sometimes they refuse because they are afraid there can be some side effects. Since osteoporosis is a risk factor for degeneration, for also worsening of for example, of the forward imbalance because of the possibility of fractures of the vertebral bodies. We on one side we should teach our patient to have a better style of life, better choices in everyday life. That is a good diet, movement, strengthening exercises, and trying to avoid smoking, reduce alcohol. But about the drug therapy, we should stress and help them to solve their the perception of the risk of just taking these drugs.
Thank you so much, Alessandra. Amy, what are your thoughts?
I think the first thing that came to mind as you kind of created this character for me, um, was I would really want to interview the fear aspect. Was there a history of a fall, or have they had a fracture in the past and that was really painful? I would really want to get to the root of that, because I can recommend many things, but with that fear as a barrier, it would be really hard to make progress, I think. So I would investigate if they knew about that fear, or they had investigated it themselves. Um, I think I followed Alessandra's thinking as well, but one other thing that I have talked to people about is maybe seeing a dietitian, because maybe there are more natural ways that they want to talk about getting what they need, and feeling strong can be maybe they're not taking care of themselves very well and they don't have the energy that they need to feel strong and confident about their movements. So I would investigate that aspect too. And I do modify my program quite a bit, depending on the level. I would be looking at their DEXA test scores, and I kind of judge what they're doing in their life. I will ask a lot of questions about, are you doing this or this or that? And if they can do these things, then I feel like I can build from that. So if how is rolling in bed, how is picking an object off the floor? Can you get up and down off the floor? And then I can think about what I can build from what they are doing and feeling confident with, and see if I can support them to get over some of those barriers through movement.
Great. This was wonderful. If I were to, just another question came through, is one I'm going to tie into what I'm already thinking about. If I go back just a little bit. So imagine this patient is at your door, and imagine you find something in your clinical exam that leads you to believe, or maybe they are unwilling to change certain parameters. Maybe the patient's slightly older, and likely you are thinking she may need surgery. Maybe she has already seen several surgeons who are all saying, maybe she's having pain deficits, maybe she's having, actual non-changeable symptoms. And she is there saying, "You are my last hope. Can you fix me?" What do you do for this patient who has clearly been told, and with your intake form, you already know the surgeon is saying she is a surgical candidate, but they are not wanting surgery. Amy, I'll have you start this time. What are your thoughts around this type of patient?
So typically, I would say this patient is saying, I don't want the surgery, but if my life is this miserable, I might have to make that decision. And, I will tell them to kind of create some kind of boundary around that decision so that we can be focused on, okay, we're trying to avoid surgery for 3 months of care. Whatever frequency, duration, that's a different thing. But, let's just put that on a side table, that that surgery is an option for you and you're trying to avoid it. And I'm going to try to help you do that too. But trying to get just a mindset change of, let's try this. And if we don't make we actually will set goals of, if we don't make to this level, then we know that it's probably the right decision for you if you're this unhappy with your quality of life at this time. Um, so I try to not shut the door on it, because if somebody has been told that and they are really suffering, it does still have to stay on the table. I just like to, if I can say, table it to the side and try something else and come back to it. If we really have tried general therapy and other things, and pain management and all of these things. Um, One other thing, and I did see a question come in about this, but I do play a little bit with some kind of abdominal binder or some kind of external support if it's a small window of time that they're trying to increase the duration of their function of their day. I will say we can try this and see if it's something that improves your quality of life enough for you to feel like this is a strategy that you can use and prolong your time away from the decision of having to make that surgical choice. So that's something that I do play with.
Great.
If I could just make a comment, Prachi, I very much agree with the theme here that Amy and Alessandra are speaking about, which is the need to intervene before the changes become structural and really difficult to handle non-operatively or frankly operatively. These are really hard cases with increased risk for problems, osteoporosis, reoperation. So I think, getting there early before you have anterior chain contracture and where you still have an opportunity to sort of change lifestyle is really important. I also agree with you, Amy. Surgical treatment in this population is really about quality of life and pain. So it's just like the patients with total knees. They know when they need to have the surgery. It's like becomes very obvious. And I think you all have an opportunity to intervene earlier and change their trajectory. I also agree with you with regard to the brace. While the braces can be effective in the short term, they can have the effect of weakening core muscles. So it's much like my spondylolysis patients. I think bracing needs to be done really sparingly because it can have a counterproductive effect in some of these patients anyway.
Thank you so much, Dr. Vitale. A few questions that I'm going to combine, sort of. Very thoughtful questions. Alessandra, I'll have you jump in first. What are your thoughts, one, on managing a patient with osteoporosis and how to teach them to load? And then also, along with that, what are your thoughts on weighted vests that are sometimes recommended for scoliosis, I mean, for osteoporosis patients, especially if they also have a scoliosis on top?
This is a good question. This is a good question. To improve or to reduce the worsening of the condition of the bones, we need to give weight on the bones. And the weight of the bones, when the patient is not prepared and he has an imbalance, he has scoliosis, we must prepare the patient and then give the weight. The weight means exercises with the weight, means jumping, means anything that can give an impact on the bones, and this has been shown that is effective on this patient. I think that first we must prepare the patient with a better posture, with simple and not too hard weights, and then as soon as possible we can move into exercises with more weights. There is no reason to avoid them when the patient has a good ability to contrast the collapse, the postural collapse toward his curves.
Great. Thank you so much, Alessandra. Amy, I'll have you answer if you would like. I also, just so that for time's sake, another interesting question came up. So you're welcome to discuss the first one, which was on the weighted vests. Separately, an entirely different thought that someone just asked was a patient that does have mild dementia. They have trouble remembering all their specific exercises. What are some of your learning tools that you give your patients just to make sure they remember to actually even do what you're asking them to do and do it in the way you wish for them to do it?
I kind of parallel with Alessandra on the weighted vest question. I do think that the recommended level of weights that they tell you to purchase online might be a little bit heavier than a person with osteoporosis should start with. So maybe starting lower. And again, I would biasedly prefer that they know how to posture before putting it on so that they're not putting more mechanical stress on what's already stressed, so that they understand their body first. I think they need training before they would put that on. And then the second question, remind me again now.
Patient that has dementia that has trouble remembering.
Isn't that funny that that's what Okay. I don't have dementia, I hope. So I tend to ask them their learning style first, right up front. So from the very beginning, we decide if using an app on their phone would be helpful. I use an audio recording of a specific exercise after we've acquired some level of independence so that they could just use it like I was at home, their personal trainer being at home and doing the exercise with them non-visually. That tends to be the best because those voice memos take up very little room on your phone, and you can play them over and over and over again. So that tends to be great. I also have written handouts of general exercises, and I also always have each one of my patients, I give a folder. So when they leave, they have handouts every time. I tell them to bring their folder and we keep adding onto it. And in that folder is a blank piece of paper, which we can write notes on. And additionally, I give them a calendar. It's a calendar by the week, and we put in exercises down the first column, and then there's some description room, and then there's a Monday through Sunday opportunity to X off what they've done. And we have it both that I tell them what I kind of want from them to achieve, and then they can actually say what they did achieve, and then we can have a good conversation about that as well. So just different tools to help them stay on track and remember what we did.
This is really, really all interesting. And I think that buy-in is so important, like making sure the patient understands why they're doing what they're doing. So hopefully that improves compliance. Another interesting question.
Can I add something
Please.
about these patients? Just that the problem with these patients is to start. When they start and they start repeating the same exercises every day, maybe with help of the the person that lives with them, and then when they get used to it, it's much easier because it becomes an habit and they just go on doing them. So the most difficult part of the therapy is to start with that. And then everything is even easier than with younger adults who have so many other things to be done and forget our exercises.
Thank you. That was great. We have our nurse practitioner, Brianna, who asked a really great question. She sees, older adolescents, young adults, and generally the parent is asking, do you think my child will have a higher risk of back pain in their lifetime? What are your thoughts on so as a practitioner, who should she be sending her patient just to get a start off point on just seeing a scoliosis physical therapist, because sometimes this is, expensive and time-wise hard to do. So if she were to sort of focus on who she should be recommending care, what are your thoughts on this type of patient? They have no pain at the moment. They're done growing. As a practitioner, who should she be saying, I think you should see somebody, just so that you can understand your scoliosis better?
I answer.
Please.
Should I answer? Yes. I think that we have to let these patients forget this possibility. Because if they start thinking about the pain that will come, the pain will come soon.
Mm-hmm.
So first of all, what I tell them is that the probabilities they have to get pain they are not so much different from the probabilities that other adults have. So I try to let them forget it and have a good style of life that is movement and everything that can help, but mostly movement, because this is what we saw that can help. And because I think that the feeling, the risk of pain coming is paying a lot of attention to your spine, to anything that happens in your spine, and you probably will have this pain very soon. And then I think that we must check, as I proposed before, if there is any sign that is a risk factor. For example, a forward imbalance is a risk factor. The COP degrees is not a risk factor, even though I think it must be studied even better. And then try to resolve a problem that is there, and not to try to prevent a problem that is not there. So if there is just scoliosis, I try to let them understand that you can do whatever you want, just move, and let's check in time what is happening, but feel confident in the possibility you will not have pain.
I think that's very powerful. I think we as practitioners are really hold that key and really can either have our patient confident in themselves. And I think just us saying you may have pain can definitely put that thought in their head. But then just kind of leaving the door open is always really nice. Amy, what are your thoughts?
I'm just, I, I think what I heard you say was there was the person who asked the question. Was she the mom of a daughter, or was it just a?
Sure. It's
Okay.
it's a nurse practitioner internally who sees patients, and generally it's the parents. Do you think my child will have pain in their life?
Yeah. So is it a possibility that you can have a conversation with the parent so that they aren't fearful, so that they don't project that fearfulness on the child? I think that's also something that's missed, that this child says, okay, I have scoliosis, but I'm willing to not think about that right now. But the parent is the one thinking about it and reminding them about sitting up straight and how to do the things. And that can be a lot for the child. So I think talking to the parent is something I would add to that. If the child is the one driving the visit, you could say, it would be nice to establish a relationship with you in the case that you wanted to come back at another time. So I'd love to meet you now. I'd like to kind of just see how you're doing, and you're doing great. And if you ever have any questions, you can come back. And maybe you're doing a little education of things just based on what they're doing right now. But I totally agree with Alessandra to put the fears at bay, whether it's coming from the parent or the child, and let them live their lives.
I think we have time for just one more question. What are your thoughts on the patient who is just not self-aware? You try everything to make them, you put mirrors in front of them, you use the plumb line. If you can, you use pictures, but they do not see these postural asymmetries. Maybe their spouse or their family member or a friend is telling them. But they themselves do not see it or feel it, and they're here because of someone else. Alessandra, what are your thoughts on this patient? My mother told me to come, my wife told me to come.
If they don't want to see it, this is a possibility. And I would wonder if they don't want. Because if they don't see it, they don't feel what is between brackets wrong with their posture. I think I must improve my ability in letting this patient feel it, because we have so many ways, photos, videos, let the patient draw his own profile or his own spine. And if the patient refuses it, this is a problem, and we will try to find a way to solve this problem. But if the patient is not able to see, to feel, I think we must find a way. We should find a way. We can find a way.
Amy, any last thoughts before we wrap up our webinar?
Yeah, I mean, this person does come to the office and can get rather frustrated with themselves. Therefore, I think it is important that we find an avenue to support them to live a healthy lifestyle, even if it isn't acquiring the ideal autocorrection. And so just that we are supporting them with making good choices about being active and staying fit and avoiding alcohol and smoking and those kinds of things that can also be a support to their existence with their scoliosis.
Wonderful. I hope everyone enjoyed today's webinar. I just got word that Amber will be moderating the October one, so that's going to be really exciting, and I hope you guys will all come. I hope you all learned something. I know I did, that I'm going to start implementing right away. Please send any questions our way. We are happy to chat. You can use my email address. You can use our Instagram account, and looking forward to seeing everyone next time. Thank you, everyone, for joining, and everyone have a wonderful summer.
Thanks again, everyone. Be well.